Ready? We can start whenever you want. Yeah. Okay. Good morning, everyone. This presentation will be replacement to the presentation that should be delivered last week. However, I believe that some um, the schedule that we received was different than the one you received. So I hope that we're going to discuss the antifungals and regardless of this separation from the schedule. I don't know if you are getting the fungi in the microbiology labs. You had it just recently, or so, no species, or how? I mean, just the families and the fungi. Okay, that was in this week. Okay, so that's good. Maybe the delay was in your benefit, maybe. Okay, the test for identifying types of fungi, right? Only candidate. Okay, so at least you had something this week. It's better than if you had it just 2 weeks ago without knowing anything about the fungi, the families at least, and at least you know there is a candida. At least that's a good thing for the time being. Yeah. Okay, so where is the fungi in the medical field? The first I'm going to mention is the role of fungi in provoking some sort of allergic reactions. Fungal allergic reactions are considered among the most common that's experienced by humans, especially we're talking the molds. Those molds actually, at many instances, some persons they get allergic from different allergic during staying home or at work, and when they look just around, there's no pet. Their food is they're taking which they're taking previously as a food that doesn't elect any problem. However, when they investigate further in the house, and especially when at the air-conditioned chambers, because this air is very humid, and the temperature over there is could be ideal at for certain species. So the mold will grow extensively especially in the ducks. That's you can see it, that's how it looks when the molds grow extensively. Um, Sometimes this is real problems even for hospitals. Some hospitals they get closed or isolated till get disinfected till because of the air conditions. Then after that we can some sort of less common but traditionally well known, especially in countries where the temperature is less than what we have here in the kingdom. In the kingdom, fortunately, the fungi has no big role in the pathology or the toxicities that experience like patients for people in Europe. So the mushroom poisoning is among the #1 poisonous materials that were ingested from the nature in the previous century. But as I said, that's not very common in our areas because of the high temperature that we have in the Middle East. Other parts is the toxins that some fungi, they could synthesize some very toxic substance like the aflatoxins that are produced by the aspergillus. They're potent carcinogens. And this aflatoxin, we use it in labs to provoke the development of cancer in animals. So it's very carcinogenic. It's very rapid in its effect when it's given in high doses. Also have the ergot. The ergot is a type of fungi that grow on wheat. It can go if it's taken erroneously, it might cause a severe vasoconstriction to the peripherals and could lead to gangrene of the hands or in the feet. Nowadays, we're using the ergot in treating migraine, like the in the medications that mimic the bromocriptine, for example. That's most is used in the current days where they're isolated from the ergot. The Fusarium mycotoxin were used in World War II, but as a weapon, but it's not used these days. Now, our interest actually is the mycotic infections. This is the name of the fungi. We don't call it mycotic infections. That means caused by the fungi. And it's considered the fourth most common infective agents in hospital setting. Hospital-acquired infections, they were used to be called as a nosocomial infections. Now, why these fungal infections in hospital, they are getting more prevalent? First of all, there's growing number of patients because of the advance in medicine. Now we can perform solid organ transplantation or even bone marrow transplantation. So all of these patients, they receive a type of immunosuppressive agents that predispose the patients to fungal infections. Also, for management of patients with cancer, for example, or for patients who receive prolonged nutritional feeding, we had to insert a central catheter to deliver the chemotherapeutic agents or the nutrition. So the presence of foreign material like the catheter, that will increase the risk of candidiasis as well. Besides that, generally the fungi are opportunistic pathogens. So with the use of broad spectrum antibacterial, so as these agents are giving a space for the fungi to overgrow in areas that they're normally present, like the areas where the neuropharynx, Candida albicans, is heavily found in the oropharynx. So patients who get immunosuppressive agents or prolonged use of antimicrobials is going to find them growing a white thrush on their tongue or in the oropharynx area. All of this because of the Candida actually is a normal flora in this area. Some diseases, new diseases, if I could label it, like the HIV infections leading to AIDS. This also is one of the diseases that most commonly patient could experience fungal infections. The most common mycosis in these type of patients are candidiasis. It's very common that the patient progress to AIDS, the syndrome, can find suffering from oral thrush. And the Cryptococcus is fungi that could invade the CSF, especially in HIV patients, and it's among the common infections experienced by those patients when it comes to a severe form of fungal infection. So we have the candida that could infect them in a mild form, while the cryptococcus could lead to a severe type of meningitis in AIDS patients. With advancing medicine also, the overall population, and that could be part of it, that generally they will have a better lifestyle and etc. So that prolongs the life expectancy in the population. So we have more elderly patients, population, sorry, they are living more, so that will predispose them to fungal infections. But their immunity, as we grow further, our immunity will be get a sort of malfunctioning. Special problems associated with immunocompromise also, like patients with who develop fungal infections. Actually, general fungal infections, they are difficult to treat. They're not like the bacterial infections, because still the fungi will grow and elect an infection. That means that the fungi heavily multiplied and will define the environment around it, so it can grow when it comes from protecting itself, themselves from the immune system of our bodies. So that means we have a difficulty in eradicating this type of pathogens. Besides the mobile population, we are talking about people traveling from endemic area with fungi to an area that's usually this type of infections, they are not present. So the traveling also helped in increasing the risk of fungal infections. We'll talk about also regarding some sort of fungi that like Tinea pedis that could be experienced by many athletes or swimmer when they share the same swimming pool. The other problem, that's logistic problem with the fungal infections, is that now we're seeing a sort of extensive development of resistant fungi to the fungal agents that we have in our hands. Yet it's not like in the same rate like bacteria, but still it is considered one of the problems facing clinicians. Now, fungal infections, why they're difficult to treat when it comes to antifungal agents? Simply because the fungal infection, fungi, they are eukaryotes. So that means they are a bit similar to our own cells. So it's not easy to find an agent that could selectively kill the fungi while maintaining or keeping or without causing a toxic effect to our cells. So that's why you're going to find it, the number of fungal agents groups, they're not, they're not similar to those antibacterial, where we only have limited number of classes of antifungal that exert their effect by a certain mechanism that we're going to discuss later. So that could be attributed to difficulty in finding agents that could be safe to humans while it could eradicate fungi. Generally, fungi, they're also aerobic. The fungi, they cannot grow well in anaerobic environments. So always you can find them growing in aerobic and in humidity. Fungi, they prefer the humid environment. And when it comes to the temperatures, also it's very close that we humans, we like. It's a temperature that's ranging from 15 to 35 degrees centigrade. Fungi, very difficult to grow in temperature more than 37, though you could find them in spore, but they will not germinate to grow in higher temperature. And that could explain why in this region of the world that the fungal infections actually they are not very common because of the high temperature. Now, which organ usually they are predisposed to the fungi? That the organs that they're exposed to the environment. We're talking about the skin and the lung. So these are the organs that firstly they are get infected by fungi. Now, for the classification of the fungi, we have, I believe that's what you had in your lab, I believe. We have the hyphae type of fungi because they manifest with a certain filamentous strands. The most common or the prototype of the filamental fungi are the Aspergillus. Also, we have the zygomycetes, that's known as a mucor. So we have the mucor infections that mean that the patient has a hyphated infection. And we have the fusarium. So these are known to be hyphated type of fungi. We have secondly, there are the yeast that are presented by the Cryptococcus, and more commonly are the Candida. Candida albicans is considered the most common Candida that could infect humans because they are part of our normal flora, especially in the oropharynx area. There's a third type of fungi that could present in a dual form. They could be presented as a hyphated fungi at a temperature less than 37 degrees or higher than 37 degrees, just in a way to protect themselves. And when the temperature gets, suitable for the growth of dimorphic fungi, then they will be germinating in a way how the yeast they are formed. So the dimorphic fungi represented by the blastomyces and the coccidiosis. I don't want you to know the type of species here. Just I wanted to know, just in general, that we have the dimorphic fungi. But it's not important to know the blastomyces and coccidiosis. I believe that you had this in your laboratory or not yet? The microbiology lab? Not yet. Maybe definitely been exposed to it for sure. I want to know that the Candida are represented mostly with the yeast by Candida. That's the prototype, and I want to know also the Cryptococcus. They are a type of yeast. And from here, I wanted to know the Aspergillus and the mucor. Those are the more important to know among the hyphated fungi. Now, this is how I'm bringing this scheme to show how the biosynthesis of cholesterol and the ergosterol. Now, the common precursor of the synthesis of cholesterol, which is a very abundant substance in our cell membrane, it's common between us and the fungi. Both they come from the HMG-CoA reductase enzyme that's inhibited by one of the famous medications to inhibit the cholesterol synthesis called the statins. So the HMG-CoA is the initial precursor for the growth of the initial substance for us as cholesterol, and for the fungi, it's ergosterols. So this should give you the notion of how similar the two sterol type compounds. So, and that could give you an impression how it's difficult to find the antifungal that will attack only the ergosterol, while maintaining or keeping the cholesterol intact. Now that's the cuts in the cell wall and the membrane of the fungal cell. And you can find that's the cell membrane of the fungal cell. And similar that what you had in your physiology courses, that how the phospholipids and how the cholesterol is play a major role in maintaining the integrity of the cell membrane of human cell. Now I want you to know that the same ergosterol is playing almost similar role of the cholesterol in the fungal cell membrane. Now, after that, above that, when we go to the externally to the cell membrane, we can find a semicell wall consists of chitin, type of protein. Then that will be followed by the beta glucan found external to the chitin layer of the fungi. And why we are bringing that, because each part of a layer of these of the cell membrane and the cell wall of the fungi, we can find some group of medications that exert their action over there. And this ergosterol, similar that how that we get the cholesterol from the internal biosynthesis of the sterol in our cells, the same thing that the ergosterol gets synthesized from the squalene that comes from messages by the DNA inside the nucleus that we submitted to the RNA to the cytoplasm, where it gives an order to synthesize the squalene that will be formed then to ergosterol. Now, those are the most important classes of antifungal that we have in our hands. We have the membrane disturbing agents like the polyenes. We have the ergosterol synthesis inhibitor like the Azole Antifungal, nucleic acid inhibitor like the Fluconazole, and the I2 anti-mycotic or spindle disruptive agents like the grizolovine. For this group, I just wanted to know about their presence. This medication is not used anymore clinically. I have the glucan synthesis inhibitor like the Echinocandins and the chitin synthesis inhibitor like the Nystatin. And for the polyenes, they're represented mostly by two well-known antifungal, the Amphotericin B, that's agents used extensively when we're trying to treat systemic infections. Only could be given parenterally. I mean, mostly it's given intravenously, or sometimes we can use it locally, like in irrigation of bladder or something in to manage some internal fungal infections. But overall, generally, it needs to be given systemically. It's very labile to the acidity of the stomach, so it cannot be given orally. So always could be given systemic. The Nystatin, it's also it's not absorbed because it's large molecule, but we only use it for local fungal infection. We cannot give it systemically because it's very highly toxic. So Amphotericin B could use it for systemic infections again. Nystatin could be used for local infection like oral thrush, or for the neonates, for the diaper, to eradicate the fungi that grow in the early days or early weeks of the life at the moist area experienced by the infants. Now, how the amphotericin exert or the Nystatin exert their action. First, it binds to the ergosterol, and that's the ergosterol, that's the amphotericin B. So when it binds to to the ergosterol, they causes, because the ergosterol is an integral part of the cell membrane. So binding to this ergosterol will cause a sort of disruption of the cell membrane. So that will open up pores within the cell membrane. And as you can see, how the structure of the Amphotericin B is a bit lengthy or long molecules. So that, as when it inserts itself inside the cell membrane, it will act as a gate. So this gate, when they're formed, that means we have a leakage of the important cations in the fungal cytoplasm. So by the continuous leak of the potassium, the sodium, that will affect the action potential, and hence that will cause the death of the fungal cell. There's another sort of accessory, called accessory mechanism for the polyenes. They could induce significant oxidative damage by oxidizing the fungal membrane, but by releasing a sort of free radicals. But that's only an accessory mechanism, and it needs to it needs that the antifungal need to be given continuously and over a long time till we can get a prominent effect. However, the most important that mechanism of action for the polyenes, that by binding to ergosterol and causing pores or channels within the cell membrane, leading to the leak of important cations. You can see that that's how the cholesterol looks, and that's how the ergosterol looks. So they are very close to when we look to them in structure, and that's why it's not surprising that also the Amphotericin B will bind with our own cholesterol. That's not surprising at all. And that's why we have these agents, the Amphotericin B and the Nystatin. They're toxic to mammalian cells because of their ability to bind to the cholesterol. This is on just I bring that to how for you to understand how the affinity or the ability of the cholesterol, the amphotericin to bind to ergosterol is the KD is how it's presented. Is a method to represent how fast or how the reaction take over in chemistry. So the KD of the amphotericin B bind with the ergosterol is 6.9 multiplied by 100,000, while when it binds to mammalian cell, yet it's lower, but still the KD is considered to be high. It's 5.2 multiplied by 10,000. So always just bear this in mind. This number is not important. Just so I'm bringing this for you to know that why amphotericin B is toxic to our cells because of this ability to bind to the cholesterol, and also will cause the leak of the cations or other agents from our own cells, especially when it comes to the kidney cells. That's the structure of the amphotericin B. As you can see, it's how long it is. So that this characteristic structure enabled the amphotericin B to act as a gate. So within the full cut of the cross section of the cell membrane of the fungi. Generally, amphotericin B is fungicidal to most of the fungi. But then this is not an absolute. It's also exerts an effect with the dose dependence. So the much we increase the dose, the much we get better killing with amphotericin B. However, the more we get complications. Similar that we had with antibiotics. Some antibiotics, they exert a sort of post-antibiotic effect. The same thing with amphotericin B, it exerts a post-antifungal effect. That means when there's a zero level of amphotericin B after its administration, the fungi continue unable to multiply, even in the absence of high levels or therapeutic level of the amphotericin B. So it's very efficient against most of the candida, especially when it comes to candida albicans. All the candida generally they are sensitive to amphotericin B, except when it comes to candida Nystatin. So Nystatin candida is resistant to amphotericin B. Also, amphotericin B is very effective against the Cryptococcus species that could infect, cause meningitis in AIDS patients. So amphotericin B is among the good choices to treat generally Cryptococcus in general. It's also effective against the filamentous fungi, including Aspergillus, all Aspergillus species, except for Aspergillus terras. That's the only exception that amphotericin B does not exert an effect. Also, it's effective against the dimorphic fungi. As I said, amphotericin B is not absorbed orally, so always it needs to be given parenterally. Now, the nephrotoxicity, similar to that, because its activity is dose dependent, so also the complications, they are dose dependent. So nephrotoxicity is the most important adverse effect of amphotericin B therapy. There's the complications could be classified generally of amphotericin B to either infusion-related toxicities and the electrolyte disturbance. The nephrotoxicity also is linked to electrolyte disturbances, but I would like just to keep it as a sole entity just to make it clear for everyone that independently, amphotericin B can cause hypokalemia and hypomagnesemia. And the mechanism of that is now, it could be clear for everyone by its ability to bind to the cholesterol and causing these channels within the mammalian cells. In certain situations, especially with the prolonged use of amphotericin B, and that's not surprising because, as I said in the beginning, fungal infections, they are difficult to treat. So mostly we need to administer this antifungal over a long time. And hence that we're gonna buy the, even some complications that's not commonly seen when it's given for a short time, but because of the nature of the fungal infection, mostly we need to treat for long term. So hematological toxicities will be evident. That includes, it will inhibit the erythropoiesis, where it depends on the release of erythropoietin from the kidney. So again, we're talking about the kidneys, but there's a different action of the kidney. And with inhibition of the erythropoietin release, that will lead sort of anemia. The type of anemia, because that's not related to micronutrients deficiencies, or it doesn't affect the micronutrients, but it affects the erythropoietin, the ability to stimulate the bone marrow to release of red blood cells. So you're going to find drop in the number of the RBCs, but the shape of these RBCs, they are normochromic with a good amount of iron or vitamin B12 and folic acid. So their shape is normal, but their number is dropping. It's not like that's what we are seeing with the iron deficiency anemia, whereas we get microcytosis, or with the megaloblastic anemia linked to vitamin B12, for example, we can find the RBCs get enlarged. The percentage of patients that experience this adverse effects is high because, again, because of the prolonged use of these agents, depending on the type of infection. Now, how the nephrotoxicity develop in patients with who are receiving the amphotericin B? There are two important mechanisms. The first mechanism that amphotericin B will cause a constriction to the afferent arteriole. So with the constricting the afferent arteriole, that means there's less blood will be delivered to the nephron, and that will lead to toxicities at the level of the nephron, because there is not enough blood supply and oxygen to perform the usual exchange of electrolytes and some important substance like the amino acids and etc. in exchange. So this besides the vitality of the cells, because of the oxygen supply, will be decreased. The incidence of developing nephrotoxicity is with amphotericin is high. 30% of the patient will start experiencing nephrotoxicity within 7 days of treatment with amphotericin B. Now, the problem when when nephrotoxicity develop, it will take time to recover. It's not like the nephrotoxicity that we see with aminoglycosides and colistin, for example, among the antibacteria. It will take sometimes weeks till we can see a normal creatine level. Now, also, you're going to find as a trend that we calculate the sum or the total number of doses that we see, because it's related, the extent of nephrotoxicity is also related to how much of amphotericin B as a total dose delivered to a certain patient. The risk of the patient will go to chronic kidney function, that means lifelong kidney dysfunction, if the total dose of amphotericin B exceeded 5 grams. Now, so how to attenuate the construction of the afferent arteriole? We'll try our best to pump the body with much of fluid, so to force the fluid to pass to the afferent arteriole. How that will be achieved by giving the patient or priming the patient with at least 1 liter of normal saline before the administration of amphotericin B. So this is one among the maneuvers that we undertake to prevent the kidney dysfunction. Another secondary mechanism how it exerts nephrotoxic effect by disturbing or causing destruction of the tubular toxicity, and that could be by the binding of the amphotericin B to the cholesterol and causing the pores inside the within the cell membrane of the renal cells, and the leak of the important cations will lead to necrosis of the cell lines in the nephron. Now, the infusion-related adverse effects, which are related to the rapid infusion that we give the patient, those adverse effects will develop more prominently. Now, the question is, okay, why it's a bothering problem? Because the problem with amphotericin B is a medication that needs to be sometimes given for weeks, and many of the patients, after receiving the first 2 weeks in hospital, they will go home and come to a day medical procedure areas to receive an infusion. So it's not realistic to keep the patient again for 5 or 6 hours every day. So most of the patients, they are keen to go just to receive the shot, the dose, and leave. So the more rapid we are administering the amphotericin B, then we hear the time we can see these adverse effects developing. So the patient will experience some sort of fever, rigors, headache, nausea, and vomiting, and more importantly, hypotension. The hypotension problem is that now, as I will adding more fuel on the fire, because the hypotension will exaggerate the nephrotoxicity of the amphotericin B when it develops. Now, it develops after 2 to 6 hours of after the infusion of the amphotericin B. So typically, what we do, the first maneuver, that we infuse amphotericin B over 4 to 6 hours, that prolong the infusion time. And we pre-medicate the patients with certain medications to inhibit the release of the prostaglandin and the cytokines that they are released or provoked by the rapid infusion, their release increased by the rapid infusion of amphotericin B. So we have hydrocortisone, the one, the steroids. We give sometimes antihistamine, acetaminophen, or brufen, one of the NSAIDs, just to decrease the risk of or the prostaglandin-related manifestations, including the fever and the headache. Usually, we start amphotericin B with 1 milligram as a test dose to assess the patient response to amphotericin B. Now, nowadays, we have a lipid form of amphotericin B that will help in decreasing the risk of nephrotoxicity. And so the amphotericin B will be incorporated into a lipid vessel. So it will act similar to the chylomicrons that you studied during your physiology courses. So the amphotericin B it distributes to high density lipoprotein, and that will allow because there's the kidney, the renal cells, they have low affinity to generate to high density lipoprotein. So we use this feature of the dislike, if I could say, of the renal cells to the high density lipoprotein. We incorporate the amphotericin B within the vessels of high density lipoprotein. So even when it goes to in the systemic circulation past through the kidneys vascular, it will not be taken by the kidneys. So that will attenuate. While when it goes to other site of infection where it's heavily loaded by fungi, it's get more absorbed or there by other tissues that like or favor the HDL. Especially like for example, it's not limited to like the liver. So it will take these vessels and extract the amphotericin B and attack the fungi. While on the other hand, they were maintaining a bit the kidney more safe. Now, Nystatin, again, it's not used parenterally. It's only mostly used in treatment of candida that could grow as oral thrush on the tongue or the back of the oropharynx cavity. It also could be used, that's frequently, by the way, it's frequently used in diaper, in the neonate and infant, that this redness could be attributed to fungal infection. We add sometimes also zinc oxide just to decrease the humidity of the area, so the fungi will not find it as a favorable environment. The molds or the filamentous fungi, they are not susceptible to nystatin, and they're not effective against, similar to amphotericin B, not effective against Candida leustiana. Now, the second class of antifungal is the Azole Antifungal. They're classified to two groups: the old generation, or the older azoles, or we call them as the Imidazole Antifungal, that include Ketoconazole or the Clotrimazole. And we have the newer Triazole Antifungal that include the Fluconazole, Itraconazole, Voriconazole, and Fluconazole. And I believe Dr. Dilip sent you a formulary of medication that you need to know. Okay, so just pick up those agents that like Voriconazole, for example, I believe is not in your formulary. Okay, so we have Fluconazole, Fluca, and Itraconazole. Generally, these agents they ends with azole. Okay, you can find the azole suffix. You can find it in all the azole antifungals. Okay, from here you can know which class of antifungal we're talking about. So now the imidazole antifungal, like the ketoconazole and the clotrimazole, they're not used systemically. Mostly now we're using them as topical agents. They're extensively used. These agents, even like the Clotrimazole previously, maybe more than 40 years back, it was one among the commonly used oral medication. It needs a sort of acidic media to be absorbed. On the other hand, the Azole Antifungal, they are well absorbed, regardless of the acidity um, of the stomach, how if it's suppressed or not suppressed, or with food or without food. So they can give in without limitations, except for Fluconazole. They are far less hepatotoxic compared to the imidazole. The imidazole, that's why we lost interest in using imidazole in treatment of systemic infections, because they are hepatotoxic. These agents, they are hepatotoxic. And these agents mostly they're used systemically, not as topical preparations, and their spectrum of activity against the fungi is broader compared to the imidazole. Now, how these agents they exert their activity? Again, they circulate around the ergosterol, but it doesn't bind to the ergosterol as we saw with the Amphotericin B, but here they inhibit the synthesis of the ergosterol. And that's by inhibiting a well-known group of enzymes. We call them the cytochrome enzyme that we share it also, by the way, with the fungi. I mean, you exposed to the cytochrome enzymes that many of the drug classes, including some certain antibiotics, that could affect the cytochrome, that could interact with other medications at the level of the cytochrome enzyme. However, here, the fungi will inhibit the cytochrome lanosterol 14 alpha, the demethylase. So the demethylase enzymes, they are not found in humans. So this specificity of the Azole Antifungal to tackle this enzyme, allow them to be toxic to the fungi, but not to our body. But that's not absolute. It will inhibit the cytochrome enzymes generally, but without causing a toxicity. So this inhibition of the demethylase enzymes in the fungi will lead to accumulation of toxic sterols. So they're not moved. The sterols, they're not moving to the next step of forming ergosterol. So these substances, when they get accumulated in the fungi, they will exert a toxic effects. And this semi-false sterol, when they are pushed then to be used to build the cell membrane, they will, as we the fungi will be ending with a non-functioning cell membrane, and hence that will lead to the fungal death. So, we're talking again simply, there is inhibition of the real building block, the ergosterol, in the fungal cell membrane. That will lead to accumulation of sterols. So this sterol will be pushed to replace the ergosterol as in building the cell membrane. Ultimately, the fungi will be ending with a semi-real cell membrane that will perform all the functions required for the fungi to live, and hence that will lead to the fungal death. So, as I said, azoles are nowadays they are among the most extensively used antifungal agents. They exert activity against yeast and others. They may also able to eradicate or kill the molds. So this is among the distinctive feature of the Azole Antifungal. Not all of them able to eradicate the molds, not like the Amphotericin B that exert a well-defined activity against molds, against candida, even dimorphic. The situation with the Azole antifungal is a bit different. Itraconazole, voriconazole, and fluconazole have good activity against most of the yeast, but not fluconazole. Yeast and the filamentous fungi. Fluconazole has only activity against the candida. I wanted to know that, please. That's the most important. I want to know that fluconazole exerts activity against candida, but has no activity against the molds. The itraconazole, I think we're gonna, oops, we're gonna skip this. This is not important for you. Let's delete this. Regarding the azole antifungal kinetics, these agents inhibit the ability to inhibit the cytochrome enzymes in our bodies, which is the 3A4 among the most important enzymes that could be inhibited by the antifungal, like the fluconazole, 50% ability to inhibit these cytochrome enzymes, while voriconazole could inhibit 90%. So most of the drug interactions could be seen with voriconazole compared to fluconazole, but itraconazole is intermediate. Also, it's among the agents that heavily interact with other medications through the cytochrome enzymes. So this is very important when you combine antifungal with agents like antibacterial agents that inhibit the 3A4, like the Clotrimazole, erythromycin. These agents, they heavily interact with the azole antifungal, and here you find sometimes yourself struggling when you're treating a patient with a fungal and bacterial infections at the same time. Levofloxacillin also among the quinolones that interact with the azole antifungals. These agents also, they suffer this adverse effect that from causing this adverse effect by prolonging the QT wave. So prolonging the QT wave could lead to torsade depoints, and the patient might end with a VTs, ventricular tachycardia. That could be fatal. Also, they are hepatotoxic. The more, as I said in the previous slide, the old generation azole antifungal, they're more hepatotoxic, and that's why now we are limiting their use to topical preparations mostly. Also, these agents are available in oral and injectable forms to be used allow for switch therapy. And there are substrates for the P glycoprotein. They are small molecule lining the small intestine where they pump back the toxic substance. That's their physiological rule back to the lumen. So these agents also, they are substrate for the P glycoprotein. That means that when we receive it orally, some of the azole antifungal will be pushed back from the cell membrane of the epithelial cells in the GI back to the lumen. The Clotrimazole, it's an example of the topical antifungal. Nowadays, we heavily used in treating vaginal yeast infections, oral thrush, and diapers. It's also among the medication that you can buy it from the pharmacy without prescription. To treat diaper infections. It's available in a cream to treat skin infection, or vaginal tablets to treat vaginal candidiasis. It covers most of the candida infections, that's why it's ideal to treat the vaginal infection candida. It's common infection that could affect the genitourinary tract of the females. Fluconazole, again, as I said, it's very effective against the yeast by both the candida and the cryptococcus. Regarding the the coverage, I wanted to know that fluconazole does not cover the Candida creusi. That's the most important bug I wanted to know. That's inherently resistant to fluconazole. As we had just a while ago, that fluconazole has no activity against aspergillus, and it's active against the dimorphic, regardless of which type of the dimorphic. The drug penetrates well in the different body tissues, and it achieves good levels in this CSF. So it's among the reasonable agents that could be used in treating meningitis, especially for treatment of AIDS-related Cryptococcus meningitis. So fluconazole among the very efficient agent to treat these type of infections. Because it could be secreted renally, we need to adjust the dose in patients with renal dysfunction, and it's available in oral and injectable form. Itraconazole, it's also available in oral form. That's the most commonly used form. It's very efficient against the molds, the aspergillus, except when it comes to teres. It has no activity. It's covered teres. This is unlike the Amphotericin B. The Amphotericin B does not cover the teres among the aspergillus, but itraconazole does cover it. Just forget about the parapsolosis, and this, the similar to fluconazole, itraconazole does not cover Candida creusi. The most important adverse effect of using itraconazole is hepatotoxicity. So that's similar to fluconazole. The echinocandins, we have among your formulary that you need to know are caspofungin and andulafungin. These agents are hepatically eliminated. They are fungicidal against the yeast, but when it comes to the mold, they are fungistatic. Generally, they are safe medications. They are among the safest agents when it comes to the antifungal. They exert sort of post-antifungal effect. Just I want you to know that's the good thing in these agents. They are safe and they pose the patient to least drug interactions, unlike the Azole antifungals. So the favorable things in this group, they cover the Candida well, excellent coverage to the Candida. All the Candida that are covered by echinocandins, and that's why we use the echinocandins in treating critically ill patients. So for critical ill patients, patient in ICU, nowadays the recommendation is to start with echinocandins. Again, they are safe, less drug-drug interactions with a wide coverage for the Candida. This is the summary of most of the echinocandins. Now, why they are safe? Because we can look to their mechanism of action. They tackle the glucan in the cell wall of the fungi, and our cells actually they lack the glucan. So by its activity again, the glucans proteins in the cell wall that render them safe because they don't interact with a sort of human cell. Now, these agents, they are only available as injectables. They're not available for oral administration. And simply you can look to the structure is really, they're large molecules, so they cannot pass through the small intestine when they are received orally. Also, they are not, they cannot use to treat meningitis, fungal meningitis, because of their large molecule, they cannot pass to the cerebrospinal fluid. Flucytosine, it's an agent that inhibits the nucleic acid synthesis. That we'll talk about the DNA of the fungi. And these agents should not be used alone. Always the flucytosine need to be combined with other antifungal agents because of the rapid development of resistance. Their activity is active only against the candida. It has no activity against the molds. The adverse effect, because it's similar, because it acts on the DNA, so you suspect that it might affect our own DNA, so it might cause bone marrow suppression because the bone marrow is rapidly proliferating tissues in our body. Lastly, are the allylamines. Those agents, they are only they inhibit the conversion of squalene to lansoprazole, and these agents nowadays, like the terbinafine, they are used to treat cutaneous fungal infections. Just I wanted to know these pieces of information about the allylamines that are presented by terbinafine, and they are all available in oral. Sorry, that's okay. Available only for to treat topical infections and to that cannot be used systemically. Just briefly, thank you very much for your time. I'm sorry for taking a couple of minutes extra for this presentation. Okay, I will keep the slides over here on the desktop. Take a break. Okay.